Okay, hello. So this is RF. Welcome to Offbeat Medicine. Let's talk about myeloproliferative neoplasms. Myeloproliferative neoplasms. So what do we have here? They're the malignant hematopoietic neoplasms with varying impacts on WBCs and myeloid cells lines. The first one we have is the polycythemia vera. It's a primary polycythemia disorder of increase in RBC, usually due to acquired JAK2 mutation. You have an acquired JAK2 mutation, important, may present as intense itching after shower. Again, we talked about something before there as well. But this is itching after shower, same thing as that, but with all other features of polycythemia vera, which we'll be talking about right now. So itching after the shower, aquagenic pruritus. It is rare, but classic symptom is erythromelalgia, which is severe burning pain and red-blue coloration due to episodic blood clots in vessels of extremities. Very important. So what do you have? You have erythromelalgia. Erythromelalgia. You have the severe burning pain, red-blue coloration, due to episodic blood clots in the vessels of extremities. It is associated with hyperviscosity. There's lots of RBC in the vessel lead to hyperviscosity. Hyperviscosity leads to thrombosis. Thrombosis of causing PE, causing DVT, causing Budd-Chiari syndrome. There is a decrease in EPO because there's so many RBCs versus secondary. Now look, very important. There is decrease in EPO in primary polycythemia, but in secondary polycythemia, which presents with endogenous or artificially increase in EPO, secondary due to some other cause, you have polycythemia, that in that case you would have an increase in EPO. Treatment is phlebotomy, hydroxyurea, ruxolitinib, which is a JAK1 or 2 inhibitor. And here we had the JAK2 mutation, so we're giving this thing to inhibit the JAK2. Okay, and that hyperviscosity, so let's talk about some detailing things here. Hyperviscosity is going to give you increase in hematocrit. The RBC is going to give you increase in hematocrit. In polycythemia vera, you have increase in all cell lines, increase in production of all cell lines. But increase in RBCs is most prominent. That's why you were just talking about RBCs, because it's more prominent. Okay. That's pretty much what we have here. So here, one last thing actually about EPO. EPO has an intrinsic kinase activity which must interact with JAK2, cytoplasmic tyrosine kinase. This JAK2 is cytoplasmic tyrosine kinase. So EPO must come in interaction with, must interact with JAK2, which is mutated, right? JAK2. So because you have the primary polycythemia, you have the mutation in JAK2, you have decrease in EPO. But in secondary polycythemia, you have normal JAK2, that's why you have increase in EPO. Okay, so important points in polycythemia vera to remember is we can have primary polycythemia, and I think they have mentioned at the bottom. Do we have polycythemias? Do we have yeah, here it's polycythemia. Okay, it's gonna come up. Well, so you have the primary polycythemia, increase in RBCs, JAK2 mutation, which is a tyrosine kinase, intrinsic tyrosine kinase. You want to inhibit that by drug which inhibits this JAK2, which is ruxolitinib, and the other one is hydroxyurea phlebotomy. Other thing, you can have an itching after shower, and you have erythromyalgia, and you have hyperviscosity and thrombosis of the veins, and decrease in EPO. Now let's talk about essential thrombocythemia. Essential thrombocythemias, meaning basically simple, that you have increase in megakaryocytes. So let's talk. You have the characterized by massive proliferation of megakaryocytes and platelets. Megakaryocytes make platelets, so you have proliferation of megakaryocytes leading to a lot of platelets. Symptoms include bleeding, thrombosis. Blood smear shows marked increase in number of platelets. You have so many increase in platelets, which may be large or otherwise abnormally formed. That because they're abnormal, there's a bleeding, but because they are continually being used, there's thrombosis. Erythromyalgia may occur. We talked about erythromyalgia in polycythemia vera, and also essential thrombocythemia. But the issue is, here we have increase in platelets, over there we had increase in RBC. So very different things. Okay. And let's talk about this myelofibrosis now. Myelofibrosis, you have obliteration of the bone marrow with fibrosis. So let's read. It is an atypical megakaryocyte hyperplasia. Atypically, you have the megakaryocytes, they go into hyperplasia, which causes to release increase in TGF beta, which increases the fibroblasts, which leads to fibrosis, bone marrow fibrosis. Now let's go back again. So again, it's myelofibrosis due to increase in TGF beta that was coming from hyperplasia of megakaryocytes, which are like the precursor of platelets, which increases the fibroblast, causes fibrosis in the bone marrow. Obliteration of bone marrow with fibrosis associated with massive splenomegaly and teardrop RBCs. Looking at C picture, teardrop RBCs. These are the teardrop RBCs. And bone marrow cries because it's fibrosed and it's at dry tap. So this is the second dry tap you're getting here. But here we have dry tap without any pancytopenia. is just due to the fact that we have increase in platelets, which cause more and more TGF-beta, which cause the fibrosis. And we also have splenomegaly and teardrop RBCs and dry tap bone marrow. Okay. So I've also mentioned here the treatment for erythromyalgia is aspirin as a treatment for erythromyalgia. You have leukoerythroblastic smear nucleated with dacrocytes greater than 1 cytopenias. So again, teardrop is the dacrocytes, and you have more than 1 cytopenia. Because it's fibrosed and massive in teardrop. Okay, what else I have here? Why do we have splenomegaly? Because when you have dry tap in the bone marrow, the other organs are going to start making the blood cells. So you have splenomegaly due to extramedullary hematopoiesis. Okay. And also you can have hepatomegaly as well. Same thing. Yeah, you can have extramedullary hematopoiesis. Okay, so that's pretty much all we have for myelofibrosis. Now let's talk about this table. In this table, we are looking at all the cell line, RBCs, WBCs, platelets, and Philadelphia chromosome, and JAK2 mutation. In polycythemia vera, we have increase in RBCs, increase in WBCs, and increase in platelets, as I mentioned that. But you have way too much increase in RBCs. It's not associated with Philadelphia chromosome, and it is associated with JAK2 mutation, primary one. So JAK2 mutation, as I mentioned, this is cytoplasmic tyrosine kinase. So what's the mechanism of the cytoplasmic tyrosine kinase? The mechanism is, first, you have the receptor activation. Once the receptor activates, then these cytoplasmic tyrosine, these JAK2s or JAKs, they're the cytoplasmic tyrosine kinase, they bind and cause phosphorylation of the receptor, which causes phosphorylation of STAT. This is just an endocrine and go through, which translocates to, now this STAT, it gets translocated to nucleus. Now when you have the mutation of this JAK2, causes continuous activation. Now it's because there's a mutation, it's continuously binding and causing the activation and proliferation of STAT, which leads to going to the nucleus and leading to proliferation of cells. That's the JAK2 cytoplasmic tyrosine kinase. So you can give, as we said, inhibit this thing by giving a ruxolitinib, which will inhibit this JAK2. Alright, coming to the next one, which is essential thrombocythemia. In thrombocythemia, we just have increased platelets. Essential, only one thing. Not a Philadelphia chromosome. JAK2 mutation is positive in 30 to 50% of the patients. Myelofibrosis, and what do we mean with that? Same thing. because that's why we have increase in proliferation because of this thing. Myelofibrosis, you have fibrosis dry tap, meaning you have no RBC or less RBCs, variable WBC and variable platelets, no Philadelphia, and also sort of have a 30-50% chance of having JAK2 mutation. CML, this is RBCs are low, increase in WBCs and increase in platelets, and Philadelphia chromosome is positive, but JAK is negative. Going back to CML, this is CML. All you had here was this Philadelphia chromosome translocation 9-22 and myeloid stem cell proliferation, in which you had presents with dysregulated production of maturing granulocytes, increase in granulocytes, all neutrophils, metamelanocytes, melanocytes, and basophils, and splenomegaly. So now looking here, we have WBCs high, all of the neutrophils, macrophages, basophils, all that, and platelets are high, but low RBCs. Okay. But it is the only one which is associated with Philadelphia chromosome in all of these. Alright, now let's talk about